Hello, I'm Dr. Marla Shapiro. I'm a professor in the Department of Family and Community Medicine at the University of Toronto, and I sit on the Board of Trustees of the North American Menopause Society. I'm joined by Dr. Michael McClung, who also sits on the board as well. He's a clinical endocrinologist with a special interest in osteoporosis and is director of the Oregon Osteoporosis Center. So for patients, and speaking from a patient perspective, if I've been on a medication for my bone health, my osteoporosis for a while, can I take a drug holiday?
The answer is yes and no. A drug holiday or a temporary stopping of the medicine may be appropriate for some patients who have taken a drug in the class called bisphosphonates. That includes drugs like Fosamax and Reclast or Aclasta. Those drugs have a unique pharmacology. After having been on therapy for 3 or 4 years, if treatment is stopped, there's a very slow off effect. And so for patients who at that point are at only modest risk of fracture, a drug holiday is considered.
So does that mean my bones are still protected? What does this off effect mean for a patient?
The bisphosphonates stay in the bone tissue for some time and continue to exert an effect on bone metabolism. And it appears that the protection from fragility fracture, the objective of treatment, continues for a year or two on average when bisphosphonates are stopped. Because, though, that's probably very variable among different patients, for individuals who remain at high risk for fracture, whose bone density is still in the osteoporosis range, or who've had a previous fracture, it's thought that a drug holiday would not be appropriate because they are variably exposed to the risk of having fractures again.
So will that decision, if I'm a high-risk patient from a patient perspective, depend on the bone density alone?
No, bone density is an important part of that, but we also look at other clinical risk factors, how old the person is, what their other medical conditions are, whether or not they've had a fracture, and how recently they have had a fracture if one exists.
So many patients will read that if they're on some of these medications for a long period of time, they may suffer a fracture from the medication, it's thought, an atypical fracture,
right,
or something can happen to their jaw called osteonecrosis. So in talking to a patient, how do you weigh their concerns about these potential risks?
Those are important discussions to have. It is true that osteonecrosis of the jaw and funny or atypical fractures of the thigh bone are associated with long-term bisphosphonate use. Those risks are very, very low. And now that we recognize that those are potential problems with long-term therapy, we can actually evaluate the patient and identify early fractures before they become a complete fracture, and can help patients with dental problems with their dental care to minimize the risk of those things happening. The likelihood of having a fracture related to osteoporosis, a spine fracture or a hip fracture, if treatment isn't taken, is substantially higher than the risk of having the rare side effects of long-term therapy.
So if I, as a patient, am not eligible for a drug holiday because my risk remains high, is there ever a time that I would go on to a different medication, or will I just stay on the medication that I'm on?
With the availability of new medications that are more potent and more effective, perhaps, than bisphosphonates, we now think that after 3 to 5 years of therapy, if a patient still has bone density in the osteoporosis range, switching to a drug like denosumab or Prolia that has been demonstrated to result in a better increment in bone density seems to be appropriate. And new drugs on the horizon are even more exciting about potential drugs to use in sequence or as follow-on drugs to bisphosphonates.
Thank you.
Sure.